Good afternoon and good evening to everyone. On behalf of the Online Media Committee at AAPOS, we welcome you to the AAPOS Adult Strabismus webinar. Thank you for joining us for this expert panel of colleagues and friends, and we know that you're going to enjoy today's talk. I'm going to introduce each one of them as well as the title of their talk. So first will be Dr. Linda Doggy, who's going to speak on adult strabismus and thyroid eye disease. And she is Director of Adult Strabismus at Boston Children's Hospital and Massachusetts Eye Institute, Associate Professor of Ophthalmology at Harvard Medical School. Dr. David Hunter is going to speak on evaluation and management of fundus torsion, and he is Ophthalmologist in Chief at Boston Children's Hospital. He is the Richard Robb Chair in Ophthalmology and Professor of Ophthalmology at Harvard Medical School. Dr. Mark Greenwald is going to speak on intermittent exotropia, bane or boon, and he's retired professor and former interim chair at University of Chicago. Dr. Mitchell Strominger is going to speak on strabismus surgery to correct diplopia after scleral buckle, and he is pediatric ophthalmologist and neuro-ophthalmologist at Retinal Medical Center in Reno, Nevada. And Dr. Federico Velez is going to speak on managing concomitant strabismus, and he is professor of ophthalmology at Duke University. Thank you very much, and the program will begin now.
Is my talk up? I can't tell.
It is.
Okay, great. So let's start with strabismus and thyroid eye disease, observations from the field. So why are we here today? Graves' orbitopathy severely impacts the quality of life. Did I lose you? Are we still here? Okay. Severely impacts the quality of life of thousands of young through middle-aged patients. Active disease can last from 18 months to well over 3 years or longer in smokers. There's an 8-to-1 female to male ratio, prevalence of over 1% in North America. Males tend to be more severely affected when affected by the orbitopathy, and smoking, hypoxia, and ionizing radiation worsen the orbitopathy. Whereas initial higher levels of TSH receptor antibody do correlate with greater orbitopathy, there is unfortunately no blood test to date to guide treatment and confirm quiescence for strabismus surgery. The euthyroid state does not prevent progression, nor does it forecast remission of the eye disease. A related but distinct autoimmune process is taking place. In 80%, oral disease occurs within the first 18 months and remits within 2 to 3 years, but some patients have chronic relapsing orbitopathy, and you'll need to wait for a stable quiescent period before strabismus surgery. While doing so, you may need to screen for compressive optic neuropathy. It comes in 2 types, the post-inflammatory type, which if present, noted by diminished vision, poor color acuity, loss of visual field, might need to be treated with orbital decompression, which itself can impact strabismus. In its more inflammatory stage, alternatives such as high-dose IV pulse steroids, orbital radiation therapy, or maybe teprotumumab may need to be considered, and decompression also needs to be on the list. And the timing and the steroid responsiveness will help you decide if you're ready for strabismus surgery. So this patient is referred to you from an orbital surgeon, just treated with IV methylprednisolone for inflammatory compressive optic neuropathy, and she's complaining of vertical diplopia, and she wants to know when you're scheduling her surgery. She's responding well to the steroids. What should you do next? Well, where is your patient along the anticipated time course of her inflammatory disease? If the signs of optic neuropathy have subsided and you're maybe a year or 2 into the time course of active disease, you may be headed towards remission and that surgery. However, if the treatment was provided early in the time course of the disease, maybe within 6 months, additional intervention may be needed to prevent rebound, which will absolutely take you away from a quiescent period. And these are the typical interventions which may be needed even a second time around, which is why you sometimes see patients who've had several orbital decompressions. Imaging can help you a lot. 25 to 35% of adult patients with Graves' hyperthyroidism have clinically apparent orbitopathy, but it's radiographically apparent in almost 90%. And it often demonstrates the bilateral asymmetric nature of this disorder with the tendon-sparing enlargement of the extraocular muscles. And it can help make the diagnosis, particularly in a euthyroid patient. MRI is useful to look for persistent activity, and there's no radiation for MRI. With T1 FATSat or FSCIR sequences, you can also often see enhancement in active disease. Likewise, with the T2 FSE fast-spin echo sequences, active disease will enhance. And so if you're not sure if the patient is still active, you could consider ordering an MRI. Let's get down to business. Strabismus. You have the activated fibroblast causing tendon-sparing enlargement of the extraocular muscles. You'll get secondary restrictive strabismus with an arching brow with fixation to rest if you have involvement of the inferior rectus muscles. And you need to suspect, look for, and treat secondary glaucoma, which often accompanies fixation to rest. Strabismus surgery is often addressed after orbital surgery, yet before eyelid surgery. The most commonly involved muscles are the medial rectus and the inferior rectus, but imaging and force duction testing demonstrates more global involvement in many cases. You need to wait for at least 6 months of stable sensory motor exam post completion of the inflammatory stage, although you may find that you're operating earlier in some cases. Technical details. The goal is single binocular vision in primary position and down gaze. We want to try to match the restrictions of both eyes. I prefer adjustable sutures, though not all providers will operate with adjustable sutures in these cases. And I prefer recessions before resections because you're already dealing with restrictive disease. We're addressing esotropia. Usually you'll start with medial rectus recessions and go on to lateral rectus resections only for very large deviations. That is not typically what is done. Treating vertical diplopia and thyroid eye disease, however, is a bigger challenge. You want to achieve a stable and substantial field of single binocular vision, including primary position and reading position, and you may need to accept a mild postoperative chin-up posture to do so. You need to warn patients about lower lid or upper lid retraction after recession. You'll need to carefully dissect from the lid retractors, and you may want to advance the pulleys separately, and that helps to reduce some of the eyelid retraction. You have 4 basic questions to answer before you go to the OR. Is unilateral or bilateral inferior rectus surgery a wiser choice for your patient? What can you do to minimize the risk of late overcorrection associated with inferior rectus recession? How do you recognize and manage superior rectus involvement? And what can you do to anticipate and address A pattern and in-cyclotorsion associated with bilateral inferior rectus recessions? First question, unilateral versus bilateral surgery. When considering whether to perform bilateral versus unilateral inferior rectus recession, I tend to consider the degree of fixation duress more than the magnitude of the relative hypotropia. Make sure you understand the causes of thyroid stares. Fixation duress is only one of them, but fixation duress is critical to this issue. Here's an example. This patient has a 55 prism doctor esotropia and only 4 prism doctors of right hypotropia after bilateral orbital decompression. Would you recess both medial recti and then perhaps recess the right inferior rectus a small amount? She's got a lot of fixation duress. Occlusion of the more hypotropic right eye fails to significantly reduce this chin-up posture and the fixation duress. You can see the arching brow and the effort it takes to reach primary position in this patient. So in this case, I would choose adjustable bilateral inferior rectus recessions and medial rectus recessions to extinguish the relative hypotropia, the esotropia. You'll reduce the torticollis and the eyelid retraction and all this fixation duress. And you're able to repair the strabismus and the eyelid retraction with 1 extraocular muscle surgery. This is a different patient. In this patient, occlusion of the left, more hypotropic eye resolves the chin-up posture. You can see the right eye elevates quite well. So in this patient, inferior rectus recession of the left eye was sufficient. Her eyelid retraction is due to Mueller's, not fixation duress. So once again, unilateral versus bilateral inferior rectus recession, consider degree of fixation duress and chin-up posture rather than the magnitude of relative hypotropia. What about late overcorrection after inferior rectus recession? It's likely multifactorial. Gravity can exert a downward force on the recessed inferior rectus, impairing adhesion to the globe. As you see here, the infraducted globe provides shortened arc of contact with the inferior rectus, favoring slippage. You can have subclinical postoperative inflammation, further contracting the inferior rectus, resulting in adhesion of the recessed inferior rectus to Lockwood's ligament. Some people use Merceline and avoid absorbable suture because of this problem. But I think often underestimated or underappreciated ipsilateral superior rectus tone causes overcorrection. And you need to check for obstructions with the superior rectus tone before you do your surgical dissection. So the slippage of the inferior rectus muscle, I think, is often not the cause. You can increase stability of the inferior rectus even on adjustable suture with Kushner and Spielman's semi-adjustable hangback or a recession, where only part of the muscle is adjustable. Or you can use these extra wide hangback adjustable sutures, which I favor for small recessions. The muscle is widely spread and there's very little central sag, so less chance, I think, for slippage. I think this issue of absorbable versus permanent suture may be overemphasized because muscle adhesion occurs well before Vicryl begins to lose its tensile strength at 2 to 3 weeks or is absorbed in 56 to 70 days. And I think excessive superior rectus tone is often the culprit. So you need to do forced ductions at the onset of surgery when the globe is firm and the results of forced duction testing are most reliable. If ipsilateral superior rectus tone causes limitation of introduction, you should reduce the amount that you plan to recess the ipsilateral inferior rectus muscle to reduce the risk of consecutive hypertropia. You need to think about whether the hypertropia is exacerbated by the contralateral superior rectus tone. If you have contralateral superior rectus tone, you'll see a more comitant hypotropia than left and right gaze, and maybe less excyclotropia than expected given the magnitude of hypotropia. So here you see a patient with a right hypotropia that's the same in primary left and right gaze. It's a large amount, 20 prism Dopplers, and he only has 2 degrees of excyclotorsion. This is typically a case when you have a tight inferior rectus on the right and a tight superior rectus on the left. Treated well with a right inferior rectus recession and left superior rectus recession, sort of splitting the surgical dose, giving you a nice comitant result in left and right gaze. I'm going to skip this to move on to A patterns in encyclotorsion associated with bilateral inferior rectus recessions. Why does this occur? The superior oblique takes over as an infraductor after large inferior rectus recessions. The superior oblique is an abductor and it encycles towards the eye. So as a result, you'll get this A pattern in encyclotorsion. Some have recommended nasal transposition of the inferior rectus to reduce the exotropia in down gaze. This, however, can exacerbate encyclotorsion, so it's not a great option in a patient with good stereopsis. So to reduce the anticipated exotropia in down gaze, you may need to titrate a medial rectus recession along for a slight chin-up posture to reduce this problem. You can monitor changes in torsion during surgery by measuring the position of the eye at the beginning of the procedure and the degree of torsional change as you take off the muscles. This has been introduced to us by Jonathan Holmes, this sort of iterative marking, and this can help you see how much torsional change you'll have. But what you learn from intraoperative torsional monitoring is how much the primary position torsional change will be altered by your surgery. You'll see the magnitude of the encyclo shift that occurs with large recessions of the inferior rectus. And the net torsional change can be added to the preoperative torsional data. But the torsional changes noted intraoperatively do not account for the impact of secondary recruitment of the superior oblique to enhance down gaze. So the superior oblique recruitment enabling down gaze for reading in the setting of a large inferior rectus recession will not be apparent from that kind of intraoperative torsional measurement. If you have too much encyclotorsion, if your patient complains after surgery, you can tenotomize the anterior 1/3 of each superior oblique or adjustable superior oblique recessions, which will reduce not only encyclotorsion, but the A pattern. And lastly, you can consider Monte Del Monte's procedure of advancing the lateral or an anterior lateral transposition of the inferior oblique, advancing the insertion above the superior border of the lateral rectus, and this can enhance excyclotorsion, reversing any encyclotorsion you have caused. So now you're the experts. You know how to consider unilateral versus bilateral inferior rectus surgery. You have some techniques to minimize the risk of late overcorrection associated with inferior rectus recession. you know how to recognize and manage superior rectus involvement, and you have some strategies to manage A patterns and in-cycle torsion associated with bilateral inferior rectus recessions. Thank you.
All right, I guess I'm up. Thank you, Dr. Doggy. I'm going to follow that up now by talking about evaluation of fundus torsion. And I thought that it would be a good opportunity to talk about this because I find that in my travels on the adult strabismus lecture circuit, that torsion seems to be underestimated in terms of its power to help answer questions about patients with strabismus. That is, everybody thinks about torsion if a patient has torsional symptoms, but what about a patient like this who has a right hypertropia and you want to know more about what's going on there? Well, if you know that the right eye is extorted, then either the superior oblique muscle is underacting or the inferior oblique is overacting, whereas if the right eye is intorted, then the inferior rectus muscle is underacting or the superior rectus muscle is overacting. So what I want to talk about today then is how we can use that torsion to help us solve these puzzles. And while most cases of abnormal torsion are caused by malfunction of the cyclovertical muscles, there can be rarely anatomical orbital pathology that will cause torsional disparity, such as this example from one of Linda Doggy's patients where there was craniosynostosis causing globe extorsion. But for the most part today, we'll be talking about torsion related to oblique muscle malfunction or vertical rectus muscle malfunction. So here's an image from what you learned in residency and what you teach the trainees. But what I've done to this is enhance this by adding additional arrows to show that the superior oblique and rectus muscles intort the eyes. That is, when I teach it, the superior people are in the in crowd, and that the inferior oblique muscles and inferior rectus muscles will extort the eyes. And this diagram has the added benefit of it also shows the tertiary actions of the oblique muscles abducting and the superior and inferior rectus muscles adducting. But at any rate, what we want to talk about is both objective and subjective torsion. So objective torsion is the anatomic rotation of the eye about the visual axis, whereas subjective torsion is the perception of what happens from that anatomic torsion. So anatomic torsion we can measure in terms of degree, that is the disc foveal angle, and that can be most easily accomplished with photographs. Now there are some apps on the phone that you can buy that can measure torsion, although what I found is that you can actually take a picture of a fundus photo on your iPhone and then put your phone into edit mode on the picture, and then you can straighten it until the fovea and the disc line up with each other. And that looks about right. There's a little guideline there. Yeah, that looks about right there. And you see, so that's -5 degrees. So that was 5 degrees of extorsion in this case. But we don't always have the benefit of the, it says screen sharing is paused. Hang on. Okay, there we go. We don't always have the benefit of photographs, and so we have to use ophthalmoscopy to judge torsion. But we also are generally not using the direct ophthalmoscope. So what I was taught by Dave Guyton was to use the indirect ophthalmoscopic view when looking at torsion. And in that case, here's the right eye in direct and indirect view. You see that we would expect to see the fovea in the upper third of the line through the fovea extend across into the upper third of the optic disc. If it's not there, so we'll blow up this right eye indirect view, then you see that if the fovea is above the disc, then you have extorsion. If it's below the upper third of the disc, intorsion. So for example, if it's right in the middle of the disc, then you have about +2 fundus in torsion. So that's anatomic assessment of torsion through ophthalmoscopy. I do that routinely. The first few times you do it, the first 500 times you do it, maybe you don't know exactly what, but once you get into the first 1,000 or so, then you have some comfort with where it is. So what about subjective assessment of torsion? We can go from the double Maddox rod test where we want precision in primary position. We'll range through other tests and into Lancaster red-green tests where you get accurate assessment of torsion relatively in different side gazes. So for double Maddox rod, you all know how to use this, but I have a few points that I consider. First is that although we're taught to put a white lens over one eye, in fact, what happens there is that you end up with pretty much every patient saying that the torsion, abnormal torsion, is in their right eye. So you're going to get that wrong about half the time. So to correct for that, well, we put a red lens over both eyes. We want to do this in a darkened room so there's no cues to torsion in the periphery. We have to use prism if necessary so that patients don't fuse the two images together because that's going to throw you off. And then finally, when the patient has rotated until the two lines are parallel, you can't always trust that the little scratch on the Maddox rod is in exactly the right place. And so to make up for that, if you don't trust your numbers, what I do is I then take this off carefully without jostling the lenses. I put a transilluminator light on the table, and then I choose some random marker and I figure out where it is and then rotate until the line looks straight. And so by doing that, so in this case, the random marker happens to be at about 96 degrees. I rotated it until it looked straight here. And now that random marker has moved over to 90 degrees. So we have a net 6-degree change. So before I rotated it, we had then 6 degrees of extorsion. So that to me gives the most precise measurement. Now, if you want to know how much torsional correction is needed, how much torsion is a barrier to fusion, because you don't have to correct all the torsion to get the patients to fuse, then the synoptophore can help. And there are a couple of different torsional slides available for that. The two I want to focus on are the hot cross bun targets and the house targets, because they have different functions. The hot cross bun targets you see are dissociative. Right and left eye are going to see different images, and so you're going to get the maximum amount, the torsional phoria, if you will. Whereas the house targets are designed to be fused. They even have different trees on the different sides, so you know if you're suppressing one eye. And this will give you the minimum amount of torsional correction needed to that you're going to need to target surgically to allow for fusion to occur postoperatively. There is also this instrument, the cyclophotometer, which I don't think that you can really get, but I bought one from a Japanese researcher who designed it at an ARVO meeting one year. And so we've been playing with it. It's really very nice because you get a quick reading just in a couple of seconds, way quicker than double Maddox rods, but it doesn't tell you which eye has the abnormal torsion. So that's the cyclophotometer. And then the Lancaster red-green test, when you really want the full picture, is, and here we have the examiner shines one flashlight up, then the patient says whether that's straight or not. If not, the examiner rotates, then the patient puts his flashlight up there, and he's supposed to move it around until it overlaps with the examiner's. And what you see is what it is here. So in this case, that's the green is the left eye. So the left eye is esotropic, it's hypotropic, and it's intorted. And then you repeat this for all 9 gaze positions. You connect the dots, and now you can evaluate both the vertical strabismus and the torsional changes as the eye moves into different positions of gaze. You do that with right eye and left eye fixating. Then intraoperatively, you can also assess not torsion in particular, but the torsional, the strength of the torsional muscles, the inferior oblique there and the superior oblique there, the relative tension of the two muscles. And as Linda Doggy alluded to, we have the Holmes dots that you can place at the beginning of the procedure see how it's changed over the course of surgery. It doesn't tell you baseline torsion, but at least it tells you the change. Although I prefer, instead of just putting dots, I use a radial marker, and then I put lines on, and then I lay a ruler across, have little tapes above and below so that I can have my baseline torsion more accurately measured. And then you can see here the change in torsion and can look at that angle. So for management of torsion, we don't really have as much time as I thought to talk about it, but I do want to at least make a couple of points. One is that, remember, patients have fusional adaptation. So there's 8 degrees of motor cyclovergence that patients can have. You can fuse 8 degrees of disparity with motor cyclovergence and another 8 degrees with sensorial adaptation. So up to 16 degrees is possible. So even if a patient tells you, yeah, the image is higher and it's tilted, and that tilt is, say, 10 degrees, it still could be that prisms alone are going to allow the patient to fuse, or maybe if you just get it down by half, you don't have to correct all of the torsion to get the patient fusing again. And then for surgical management, we, again, we're not going to go into much detail, but I do want to make one point about this, and that is when a patient has an A or a V pattern. So an A pattern on the left here, is generally going to be associated with intorsion, a V pattern with extorsion, but not always. And so if you don't have torsion, then you can transpose say the patient has a V pattern, transpose the laterals up, that's going to correct the V pattern. But if the patient already has extorsion and then you transpose the lateral also, then you're going to make the torsion way worse. So I have to know the torsional status of the eye before I can decide how I'm going to correct an A or a V pattern. So as I say, we won't go in any further to the surgical details. I do have a book chapter on this with a link that's shown here. If you're interested, it's in Rosenbaum's and Santiago's great book on strabismus. And just want to thank you and remind you that it's not just the patients who complain about torsional disparity, it's any patient with cyclovertical strabismus. If you know the torsional position of the eyes, you're going to be a lot closer to getting to the right surgical answer. Thanks very much.
Okay, I guess I'm next. I want to thank you all for participating. I'm delighted to be a part of this webinar. I'm going to talk today about a variety of strabismus that I'm sure all of you have had considerable personal experience with, intermittent exotropia. And that, oh, there we go. Okay. My intention is not so much to inform as to make you maybe understand this very common condition in a somewhat different way. So what I'll call pure intermittent exotropia is a form of what I like to call essential strabismus. There is no known associated pathology, and patients are typically otherwise normal and healthy. The eyes align normally a significant part of the time, and when they are aligned, visual function is typically completely normal. We think of intermittent XT as common in horizontal strabismus, but it's actually quite common to see a small accompanying vertical deviation or variation with respect to horizontal or vertical gaze. Only rarely, however, is it accompanied by DVD or nystagmus. While in most cases of intermittent exotropia, one eye consistently deviates, amblyopia is exceptional, prevented from occurring by the frequent experience of normal vision during periods of alignment. Most people with intermittent exotropia maintain the capacity for completely normal stereopsis when their eyes are straight. Stereo is completely absent when strabismus is manifest, although somewhat surprisingly, most patients don't notice that it comes and goes. Nearly everyone with intermittent exotropia develops suppression that virtually eliminates awareness of diplopia. Nevertheless, the fusional convergence mechanism can access visual input from the deviating eye to recover alignment with remarkable precision and efficiency. Though it should not be surprising, many clinicians seem not to recognize that when exodeviations manifest, the binocular field of vision expands toward the side of the deviating eye. It contracts to normal when the eyes align. Some patients are quite aware of this. Many find it an asset, while for a few it's an undesirable distraction. Here's a graphic illustrating my previous point. Notice well that esotropia results in contraction of the peripheral binocular field. Every patient with intermittent exotropia has, at least initially, the ability to maintain alignment at times with the use of motor fusion. Most do this more effectively with near viewing, where the benefits of stereopsis are greatest. Fusion control tends to be less effective in association with fatigue or inattention, times when, significantly, expanded visual field may be most valuable. That's a point I'll come back to later. Finally, a few words concerning the natural history of intermittent XT. We're all aware that it often progresses to greater frequency or larger angle, usually very gradually. It is equally true, however, that there is sometimes considerable spontaneous improvement over time. Even when deviation becomes nearly constant in maturity, potential for normal binocularity when the eyes align usually endures. It should not be too surprising that many intermittent exotropes are not much bothered by their strabismus. The most common complaints among adult patients relate to appearance. Needless worry about potential harm to vision is a factor that leads many to seek consultation and treatment. For those who are sufficiently bothered, surgery is generally the treatment of choice, with no particular procedure having been convincingly shown clearly superior to others. When I was a newly minted strabismus surgeon nearly 40 years ago, my approach to this condition was strongly influenced by the views of my esteemed mentor, Dr. Marshall Parks. I operated often and early, almost always choosing to do bilateral lateral rectus recessions. Experience confirmed for me, as I imagine it has for all of you, that most patients were very happy with the improvement they got from surgery. But in many cases, the condition slowly crept back over time. Especially following lateral rectus recessions, it is common to see early post-op esodiviation associated with diplopia, often constantly manifest. This usually resolves spontaneously in a few weeks, but it may persist or worsen, sometimes requiring reoperation. Occasionally, especially in young children, it can result in permanent damage to binocular function despite its transience. There's not a lot of consideration of these issues in the strabismus literature, but a paper published 5 years ago by Dr. Jonathan Holmes and colleagues, based on data from the Mayo Clinic, provides confirmation of my impressions from personal experience. The authors reviewed the records of a substantial number of typical patients with intermittent exotropia, similar in terms of initial characteristics and exam findings, half of whom had undergone surgery and half who had not, with very respectable follow-up. They found that only 30% of operated patients met reasonable criteria for cure 5 years or after surgery. On the other hand, about 10% of the unoperated patients had improved sufficiently to be no longer symptomatic. Final XT angles were smaller in the operated group, but very significantly, in my opinion, there were fewer patients with subnormal stereopsis in the non-surgical group. Bummer. But there might be a bright side. There is, if you look at it the right way, I think. Let's step back for a moment and consider what's actually good about, or at least not bad, in having intermittent exotropia. Well, visual potential rarely suffers. Bothersome visual symptoms are rare. A performance of everyday activities is seldom negatively impacted. And the visual field is sometimes supernormal, especially at times when that can be a most valuable asset, possibly even life-saving. To further put this in perspective, consider that the binocular field of vision varies greatly from one vertebrate species to another. Predatory animals have relatively narrow fields, strongly directed toward potential prey. Animals that tend to be preyed upon have wide panoramic fields. Humans fit right in the middle. Why so? Well, early man, in the period when evolutionary pressures were greatest, was often a predator, but also not uncommonly potential prey. How valuable must it have been to have a visual field that was sometimes very forward directed, but sometimes more extended? In short, having intermittent exotropia might have been a highly useful trait promoted by Darwinian natural selection. But success in passing one's genes forward depends not just on personal survival, but on success in mating and reproduction. Following publication of his groundbreaking Origin of Species, Charles Darwin devoted a sequel volume, The Descent of Man, to what he called sexual selection. Now, we can't really construct the Paleolithic dating scene. It's hard enough now to imagine finding a life partner without access to the internet. Well, let's try to gain some insight by looking at more recent evidence. Here's Exhibit A, the 20th century French intellectual giant Jean-Paul Sartre, who was awarded but declined to accept the Nobel Prize for Literature in 1958. Pretty blatant XT. Yet he managed to attract and hold on to as a mate Simone de Beauvoir, herself a renowned author and scholar, who also may have had exotropia based on this photo of the couple. Now here's the man who undeniably has exotropia. It didn't stop him from being named sexiest man alive by People magazine in 1996. And here's a woman who definitely has exotropic appearance at times. She was described as the best looking human being I have ever seen by the fashion designer Ralph Lauren, quoted in a newspaper article that also confirms her having strabismus. Kate Moss was one of the first celebrity supermodels. She too has acknowledged having a quote unquote lazy eye. It didn't keep her from appearing on the covers of magazines designed to appeal to both men and women. Marilyn Monroe, anyone? In her younger years, her eyes seemed to have been consistently straight. But as time passed, it became increasingly evident that she had exotropia. The appearance is quite striking in this still from an outtake of a scene in her last never-released film. And last but not least, consider the 35th US president. It's been a matter of controversy whether JFK indeed had exotropia, but it sure looks like it in this official portrait with his wife Jackie, and in many other posed pictures and snapshots. The family resemblance between President Kennedy and his brothers Robert and Edward, who were also both elected to the US Senate, seems possibly to have included this trait. So based on what I've just shown you and a lot of other evidence, I have to conclude that looking a little or even a fair amount exotropic is not necessarily a significant liability for many people. I now never urge a patient or a parent to view XT appearance as a problem, though I certainly can agree with their own feeling that it is. When parents seem overly concerned for their offspring, I will often, in addition to reassuring them about the usual lack of harm to vision from even very long-standing intermittent exotropia, call their attention to some of the figures I've just shown you. None of whom, by the way, had I noticed looking exotropic before I began researching this a few years ago. And I always ask adult patients if they are aware of their visual field superpower and warn them it will be gone after surgery. After 40 years of real-world experience, I still have no problem operating for intermittent XT, but only if an adult patient really desires surgery for legitimate reasons, or parents make a good case for their child's suffering. I almost never operate before school age and support waiting until adolescence if there is any resistance on the part of a child. I've also switched to mostly doing medial rectus plications as my primary surgical approach, but that's another lecture. I'll conclude with a somewhat unsettling story that was not intended to make a point about strabismus, but for me it took that turn. This was front page Chicago News in December 2018. Two police officers pursuing a suspect along a railroad line were killed by a train they did not hear because of noise made by another train coming from the opposite direction on a parallel track, or C, because it was approaching them from behind and its headlight was overshone by that of the oncoming locomotive. I immediately thought that things might have turned out differently if one of these cops had been exotropic, which neither seemed to be per their photos. My second thought was, I'm sure glad I hadn't operated on either of them for intermittent XT. Well, thank you. Again, it's been my pleasure to do this. Oh, just one more thing. Last night, watching the Democratic National Convention on TV, I happened to notice this gentleman, and drew a conclusion you probably will too. Thank you.
Can you all see my screen?
No.
Um,
No?
We see your screen, but not your presentation. We see your web page.
Let's see. Let me end I had it up on slideshow. And let's try this. Now. I'm having trouble here.
Just start your show and then make it full screen.
Yeah, I did all that. Unfortunately, I'm still having trouble.
You're almost there. Just that upper right corner, the thing that makes it your full screen. There.
See it now?
There you go.
Yeah.
That's it.
Great. Okay. Thank you. All right. Can you see my cursor?
Yes.
Okay, great. So I'm going to talk about rectus muscle advancement for the treatment of ocular misalignment following scleral buccal surgery. And I want to shout out to Shelley Klein, the orthoptist I worked with. You know, without orthoptists, we'd probably be nowhere. And Kirsten, who was one of the residents at the time who helped me put together some of these cases. So, you know, we don't see a lot of this, but sometimes we do see patients with strabismus following scleral buccal. I don't know why we don't see more of it. It's usually probably temporary from some sort of edema, muscle hemorrhage, or breakdown effusion. And then all of a sudden it goes away and the patients don't necessarily complain. But in some studies, anywhere between 5 to 25%, it can be permanent. And so why does that occur? It could be from scarring. It could be they accidentally disinserted the muscle. It could be some restrictive process secondary to the buccal. Maybe these patients had staphylomas or migration of the buccals, fat adherence, or anesthetic myotoxicity. So there's all sorts of reasons why people might have it. And here's just a photograph or a drawing, obviously showing that the buccals are sitting behind the muscles. That's where they're placed. So it's not surprising that there might be some issues following scleral buccal. So how do we treat this? You know, in the old days, I used to say, well, take the buccal off and let's see if things get better and then follow them up. But what I found was that it didn't seem to make much difference. And not only that, if you ended up having to go back and do surgery, there was much more scar tissue that was caused by the retina surgeon taking the scleral buccal off. So I don't really recommend that anymore. And then you have to think about, well, how are you going to do the strabismus repair? And there's not a whole bunch of literature on this. David Coates and Scott Alissi published an article talking about recession of the presumed restricted muscle. And what they would do would be to hook the muscle behind the buccal, take it off, and then do a standard recession based on your measurements. And if you couldn't dissect it off the buccal, they had this photograph or this drawing where you actually can insert the muscle from the buccal and then move it back. So, you know, in thinking about this, this was one of my first cases, and it was a 59-year-old who had retinal detachment in the right eye. She has scleral buccal. She was 20/70, and she had about a 30 diopter exotropia. And she also had an adduction deficit of that eye. So I'm like, okay, fine. So I'm going to go in. It should be pretty easy. I'll find the lateral rectus muscle because she's exotropic, and I'll recess her. I also did a prism adaptation test to make sure no matter what I did, she didn't have diplopia, and she did not. So, so this was my plan. I was going to recess the lateral rectus muscle and resect the medial rectus muscle with an adjustment. But I was surprised when I got in there because the right lateral rectus muscle was scarred way behind the equator. And so there was no way I could even disinsert that and recess that for the exotropia. So then I went in and explored the medial rectus muscle and found that it was scarred 5 millimeters behind the original insertion and behind the scleral buccal. Well, now what do I do, right? So what I ended up doing was resecting that medial rectus muscle and advanced it over the original insertion, to the original insertion over the buccal, and did my adjustment. And she had a slight exotropia in the PACU, and I tied it where it was. And, you know, she still had a little bit of an adduction deficit. And 2 years later, she had a 12 diopter exotropia, but she wasn't diplopic, and she was happy with the alignment. So I started thinking about these and then collecting all the cases that I've seen since then. I have about 15 of them, not a huge number, but they ranged from 29 to 79 years old, and some were esotropic, some were exotropic, and some had a small vertical, and the deviation ranged from anywhere between 20 to 60 prism diopters. And so initially what I would do is I would explore the agonist. So if you're exotropic, then I would look at the lateral rectus muscle to try and assess it, the antagonist, and see where the muscles were, and then base my surgery based on that. But what I started to find was that both muscles were scarred on or behind the sclerobuccal. So the question is, if you're going to go in there and explore the agonist muscle, in this case exotropia, and find that the lateral rectus muscles are scarred behind the equator, well, you can't move those. And so what's causing the exotropia, and it may be that really what's going on is these muscles are scarring behind buccals and then causing almost like a Fadden or a posterior fixation suture. So if you're exotropic and the medial rectus muscle is scarred behind the buccal somewhere, then it cannot adduct the eye. And so you can't recess the lateral in these cases of exotropia. What you have to do is resect and advance the medial rectus muscle. And I started doing that on a suture. And here's another case, a 66-year-old gentleman. He was 2100 in the eye, and he had a 20 diopter right exotropia in the sclerobuccal, and he had an adduction deficit. And so when I went in, you find that the right medial rectus muscle is scarred behind the buccal. So the yellow arrow is the buccal. The medial rectus muscle scarred behind that, and that's the hook here. And I couldn't even pull it up towards the buccal. And so based on the 20 diopters, ended up resecting 3 millimeters and then advancing it up to the original insertion and doing an adjustment. I didn't really need any, and postoperatively 1 month later, he showed a little bit of exotropia and hypotropic and alternate cover test, but was able to start fusing that and was not diplopic. And this is another case of a 60-year-old. This patient had bilateral retinal detachments, and it was a very complicated case because he has had a dislocated intraocular lens in one eye, and the left eye had an IOL exchange, and then that eye, the IOL was removed, and he was left aphakic. And he primarily had a right esotropia by Krimsky of 60 diopters with an abduction deficit. So remember, he was esotropic. So when I got in there, I found that the right medial rectus muscle was scarred at the insertion, and this was actually in front of the buccal. So I recessed that 6 millimeters with an adjustment. But you can see here in this photograph, look where the lateral rectus muscle, was 9 millimeters posterior to the insertion and way behind the buccal here. So here's the lateral rectus muscle here. You can actually see the shadow of the sclerobuccal here, and here's the original insertion. So we advanced that the full 9 millimeters on adjustable suture, and the medial rectus muscle, that was the one I adjusted actually. The lateral rectus I just pulled up to the original insertion, and he was really pretty orthotropic in recovery, and I did not adjust it. And here he is post-op day number 6. So I started thinking about these patients because all of them had rectus muscles that were scarred posterior to the buccal and in the place away from the deviation. And in all 13 cases, the underacting posterior fixated muscle was advanced to the original insertion with adjustable sutures. In the 2 cases that were greater than 60 prism diopters, I also had to try and recess the agonist muscle as well. 4 of the cases did require a little bit of adjustment for slight overcorrection, and the final deviation actually was pretty good, and all patients were less than 15 prism diopters. So in conclusion, the surgical advancement with possible additional resection of these scarred muscles actually is critical in reestablishing ocular alignment. And depending upon the degree, now I don't necessarily even go back in and look at the agonist muscle because I know it's going to be scarred posteriorly and there's nothing I'm going to do about it. And so finding that muscle that's scarred behind the buccal that's causing more of a fat end type of posterior fixation problem with the deficit and advancing that and resecting that is probably the way to go. Thank you.
Hello? Second. Can you see me?
Not yet.
What about now? Can you see my screen?
We see you, but your screen is just white.
Now we do, Dr.
Yeah,
You
Rod.
do? Okay, great.
Yeah.
Perfect. Okay, so good evening. And I want to thank AAPOS for this very kind invitation to be here today. And it's fantastic to share this presentation with all of you and have a great panel today. I'm going to talk a little bit about concomitant strabismus. It's really a very big topic, so I'm going to try to concentrate on some of the things that I do when I'm treating patients. Let me just be sure this is advancing. These are my disclosures. They're not relevant to this presentation. And why it's important? It is important because a straight ahead is not enough. Driving, walking, reading, golfing, tennis, biking. So I think it's very important to always look beyond primary position and reading position. And this is a patient that, as it said, let's see, she has an orbital fracture. And you can see there's some limitation to elevation. Actually can affect a patient a little bit when he's playing tennis or maybe golfing, but there's also down gaze limitation. So this is really critical on a patient that is orthotropic in primary position. There are many surgical procedures that we know work for these kind of situations, including pharein operation, gaze surgery for lateral incomitants. You can do recess or resect of the same opposing muscles in one eye, both vertical or both horizontal muscles, and oblique muscle surgery. So I'm gonna go with a little bit of what I normally do, try to teach fellows and residents. I love doing adjustable sutures. And it was back, I believe in 1984 or something, that Alan Scott first mentioned the single muscle resect procedure. I know Linda mentioned briefly something during her presentation. And basically it's a procedure where you can recess and resect the same rectus extraocular muscle. In his original presentation, he resected more than he recessed. And basically the less intraoperative risk is the less risk of perforation, but the advantage of postoperative adjustment. And when we adopted this, I was at UCLA back in 2005, and we actually call it the adjustable pharein operation, understanding that this is not the typical pharein posterior fixation suture, but we call it because it was easier to teach our fellows and our residents the meaning of the procedure. And basically what we did, we decided how much surgery to do based on the amount of recession. And then our resection was half the amount of the recession that we performed. You can modify this depending on the primary position, but this is kind of the principle. And this is a patient actually that I treated here at Duke University. This is a patient that had pemphigo, ocular pemphigo, and she had limited abduction in both eyes. She had 32 prism diopter of exotropia in right gaze, 14 in left gaze. And we did this combined procedure with the oculoplastic team. They did the right eye. I actually operated on the left eye and did a resect on adjustable suture 4.8 millimeters. This patient actually was operated 2 months ago and came today for the follow-up and pretty much for the lecture. So this is the patient. She's completely corrected in right gaze. So here is where I operated this medial rectus, and in left gaze, it still has a residual exotropia, we didn't really operate it. You can see actually the retraction that is caused by the tight conjunctiva here. And here you can actually see when I'm rotating her head, asking her if she can see single vision. And I can pretty much rotate her head all the way to her left, and the patient does not complain of double vision. Interestingly, when we rotate her head to the right, she actually shows some improvement. Okay. What is this slide important? Well, it is important for me because even though you can correct a little bit in primary position, the amount of correction in the primary position is very small compared to what you correct in the concomitant field of vision. I want to add something that I found is very important because I'm doing very large procedures, especially on the inferior rectus muscle, to correct this kind of problems. And there is this called semi-adjustable suture procedure described by Bert Kushner. In 2004, there was a paper by Spellman, much longer before, but to me was introduced by Kushner. That was the first person I read this paper from, and basically consists of a procedure where you can actually reattach the muscle where you want it. So you do a scleral fixation at the distance that you selected is where you want to fix the muscle. But then what you do is that you collapse the two insertional points. And then this creates a central gap on the muscle. This central gap is actually created intentionally to put the central part of the muscle on an adjustable suture technique. So this semi-adjustable suture is something that I do. You can see you can advance the muscle if you are overcorrected. And I personally like doing it on the inferior rectus muscle. But also, it has another advantage. You can do this procedure when you're doing large recessions, but remember, when you're doing adjustable suture and you're transposing the muscles to correct either torsion or a pattern, probably the effect of the transposition is actually decreased by the recession that you already did. So one of the advantages of doing this semi-adjustable is that since you're fixing the muscle on the sclera, the net effect of the transposition remains because you're actually fixing the muscle on the sclera where you want it. This procedure can be modified by placing non-absorbable suture. I used to put non-absorbable suture in all inferior rectus, but I don't like that because the suture can extrude through the conjunctiva. But you can do this technique that I learned from David Guyton, where actually the knot is placed under the muscle. So the muscle is really never exposed. Or if you really want to do it on all muscles, but you don't want to go in the situation where you're putting too many sutures, you can just put a single arm suture. It could be an absorbable suture, just capturing the central fibers. And that suture can be fixed on the sclera, and you can adjust the central part of the muscle without needing to have too many sutures. I think it's a great procedure. I'm going to move to large horizontal deviations. So I think more important than in children is adults with more than deviations greater than 30 prism diopters. For Kostenberger, more than 30 was considered a large angle isotropia. And this is arguable. Some people will say that this is a small, but to me it's important because resect procedures create lateral incomitance. So it's always challenging to know how much to do to prevent this lateral incomitance. And we know that patients with intermittent exotropia, to begin with, have lateral incomitance. So I actually have done an algorithm that I learned just by trying. Is my number one. The number two belongs to another surgeon because we did a paper together. This was his algorithm, but the number one is the one that two of the surgeons on this paper performed. And basically what I do is I divide the amount of deviation by 2, and I calculate how much resect I'm gonna do in the one eye that I'm doing 2 muscles. And then whatever muscle I'm gonna repeat on the contralateral eye, I just do exactly the same amount of surgery that I did on the other eye where I did the recess straightening procedure. And this is actually interesting because the lateral incomitance, that's all the results I'm presenting, is really rarely induced, as you can see on this result table. And a lot of patients with exotropia, I don't remember how many we have with esotropia, it was really rare to create lateral incomitance. So I like to do this in patients that require to have surgery with more than 30 prism diopters. I like to do 3 horizontal rectus muscles to prevent lateral incomitance. And as you know, lateral incomitance is induced with any asymmetric surgery, recess, resect. But if you start with lateral incomitance that is very significant, then consider doing asymmetric surgery. Basic surgery is gaze surgery. In other words, do the medial in one eye, do the lateral on the other eye. That helps you a lot with correcting lateral incompetence. Releasing the scar tissue is very critical. This is a police officer who actually came to me, and he had significant double vision that it was caused by multiple pterygium surgery done in the past bilaterally, and he had this symblepharon causing significant restriction to A deduction. Here, on the next slide, you're actually going to see how much restriction was caused. Releasing this is critical to manage lateral incompetence. And then you can do whatever surgery you need to correct the patient's horizontal misalignment in the primary position. In general, just releasing this symblepharon with or without membranes, grafts, or anything you want can correct the ocular misalignment. I highly recommend that you always look into the contralateral gaze of field, especially if you're gluing grafts, because that can cause limitation to A deduction with the result of exotropia in the contralateral gaze, which may need then later to be repaired by operating and doing one of these foreign procedures on the contralateral eye. What about vertical and lateral incompetence? Okay, so this is a patient that has Graves' disease, as you can see, and oops, I'm sorry. And she has, I'm sorry, I don't know why the video is not running. Well, okay, I'm just gonna move forward because for the time, but this patient had a big time lateral incompetence. So I'm sorry, I don't know, the video doesn't run well, but she had like a severe inferior oblique overaction, but she had very small deviation compared primary position to lateral gaze. It was tremendous. So when do we add the oblique muscles? And back in 2013, I was part of a group at UCLA where we did this procedure with inferior oblique recession, not necessarily to manage patients with inferior oblique overactions or superior oblique pulses. Is how much lateral incompetence is corrected by recessing the inferior oblique, which is my procedure of choice. And what you can see is almost half diopter per millimeter in the primary position, but is almost 3 times more correction in lateral gaze. So I love doing these inferior oblique recessions when I have these lateral incompetence and small deviations in primary position. Or if I need to add another muscle, it's very helpful. What about the superior oblique? Well, this is actually an old graph, 1975, Robinson and Alan Scott. And this is very interesting because this is a mathematical model of the superior oblique tendon. And what is the interesting part of this? Well, this is the superior rectus. Here are the anterior fibers, medial fibers, posterior fibers. And you can see not only the middle and the posterior fibers of the superior oblique are working with the vertical deviation. This is actually the vertical action of the superior oblique in primary position and in down gaze. And yes, in down gaze, most of the down gaze is given by the medial and posterior fibers. And that's why a posterior tenectomy, as was described by Dr. Julio Prieto Diaz many years back, I believe it's 1978, is a great procedure to treat patients where the lateral incompetence is creating a hypertropia in lateral gaze, the opposite of an inferior oblique over elevation in A deduction. And last, this selective rectus muscle surgery. I'm really very enthusiastic about this whole idea of how we can weaken muscles in the field of action. And I always refer to these graphs that come from the lab of Joe Dimmer at UCLA. And you can see this is actually based on innervational patterns of the medial rectus and the lateral rectus. The horizontal rectus muscle compartmentalization shows that they're very well defined in the upper and inferior compartments, both the horizontal rectus muscles. The vertical rectus muscles, the inferior rectus has dual innervation medially, but the superior rectus muscle is just a mix of innervation. And this is important because these are the temporal fibers of the medial rectus, of the inferior rectus. These are the fibers that create more tension for torsion, for A deduction. So that's why when we transpose the medial rectus muscle temporally, this here that has dual innervation perhaps has more action. And perhaps when we transpose the medial rectus medially, not only because mechanically it's a shorter distance with the orbital apex, but also because maybe this lack of dual innervation, these fibers will need to be resected. This is in theory. I cannot prove because I don't have any measurements of force on these extraocular muscles. This is a graph from Alan Scott in 2000 at the Smith-Ketwell Jampolsky's Fellowship. And he presented this, which was my introduction to the partial tenotomies procedures as he been described. So back in 2015, with Stacy Pinellas and Melinda Cheng, we put a paper together where we actually try to correct what we call selective vertical procedures to correct hypertropias, depending on if the hypertropia is worse in right gaze or if it's worse in left gaze, and if it's worse in up gaze or in down gaze, we're basically are cutting the muscle or we're doing selective plications. But these can also be done for patients that have torsional component of the strabismus. You can plicate muscles or you can weaken muscles. The plications are definitely stronger to correct torsion than the weakening marginal procedures, but they're both very good. They're limited and you have to cut a lot of these fibers, but these are procedures that you can do in the operating room with the patient awake, so you can actually control the procedure intraoperatively. Last, recently we put this paper together that we recently published, and it's interesting because this thing about doing this compartmental surgery, this is all based on MRI scans done by Dr. Dimmer and his group on how the muscles behave. And if we look at the extraocular muscles, and we look at Herring's law and Charrington's law, the muscles do not contract and relax entirely. So each compartment is actually working very differently. And if you look at this graph, there is an asymmetric superior and inferior compartment contraction during adduction on the medial rectus. But for example, the entire lateral rectus muscle is relaxing. And if you go in abduction, it's the same. There is an asymmetric contraction between upper compartment and lower compartment. Why is that important? Last two slides. Well, because back many years back, 30 or 40 years ago, Bongrave even longer, and very, I think it was in 1970 or something, they both described procedures to manage not only A or B patterns, but also to manage concomitant horizontal misalignment. Patients with convergence insufficiency type of exotropia, patients with divergence insufficiency type of isotropia. And in my opinion, the reason is that you can manage these compartments by tightening or weakening those fibers. Last, this is something that actually, if you look at the literature, you can find out so many references that you can actually treat convergence insufficiency exotropia by doing a slanted recessions of the inferior rectus, lateral rectus, or you can actually do an tightening of the inferior fibers of the medial rectus, and you can treat also convergence excess isotropia or pseudo divergence excess of exotropia. I want to thank so much for your attention. Thank you for having me here today with you. Can you see me there?
See most of us. I don't see Mark.
Okay, I'm done. All right,
Yes.
perfect. Yeah, I don't see Mark.
Wait, oh, there we go.
We seem to have lost our moderator.
Penny, are you still on? Oh, yes, I am. Dr. Greenwald, there was a question. This is Jennifer Galvin. We're talking about questions. Dr. Greenwald, there's a question about why have you switched to medial rectus resections for intermittent exotropia?
I don't think I can answer that adequately in a very short time. But I'll say that I was disappointed in the results I was getting with lateral rectus recessions, even very large ones, in adults with large angle exotropia, of whom I saw quite a few in my practice in Chicago. And so I began doing 8mm medial rectus resections, which have been popular at the University of Illinois when I was a resident there. It was a favorite procedure of Dr. Martin Urist, who had been a major influence on Chicago strabismus practice for many years. And I found that they worked very well, much better than the recessions. My colleague Sarah Rodriguez and I are in the process of putting together some data on our experience there. And then more recently, both Sarah and I have begun doing plications instead of resections for many cases where we want to tighten the superior, rather tighten particularly the medial rectus, and have been very pleased with the results we've gotten from that as well. And it's a considerably safer and easier procedure than resection. We've done up to 8mm of resection on the plication on the medial.
Oh, thank you. Dr. Strominger, there was also a question about when you wanted to advance, that you had mentioned, do you want to put the suture, hang it over the scleral buckle, under, or onto the scleral buckle? And you had said over the scleral buckle. If you wanted to mention a few more pointers about that, or?
Well, you know, it's kind of funny because the numbers for some reason just seem to work out. You know, so if the muscle is scarred behind the buckle and you calculate how many millimeters there is for the insertion, a lot of times what happens is you end up just advancing the muscle to the original insertion and doing it adjustable, and that's where it ends up being. I pull it up over the buckle. I do have one case, and I didn't mention it in this series, where the buckle was one of those old, very bulky buckles with a sponge. And actually, I just literally dissected a track. I took out part of the sponge and the buckle, being careful not to injure sclera, and then pulled the muscle up in that tract I created by taking out part of the sponge. But if you just pull it up over the buckle and it scars in there, it seems to work.
Okay. Well, if are there any further questions, Eric? I don't notice, Dr. Pennick, that there are any other questions that have come through.
No, there are some others that came through, and then I posted the questions, or posted the answers to the questions as they came up. So hopefully the audience had a chance to go in the dashboard or the control panel under the questions, and the answers were posted from the speakers.
Well, I want to thank you, Dr. Daghi, Dr. Hunter, Dr. Greenwald, Dr. Strominger, and Dr. Velez for joining us and sharing your expertise in this broad range of topics. And thank you on behalf of AAPOS for having us have this webinar on adult strabismus.
Thank you.
It's been a real pleasure.
Thank you so much.
Good night.
Thank you. Good night.
Night.